Well, welcome to Viewpoint. Good afternoon. And our guest today is Melendez Drier from the Counseling Center of Yorktown Heights. And my co-host is Susan Solomon, Executive Director of Drug Crisis in Our Backyard. Hi, Sue.
Hi, good evening,
Hey.
Lily. Nice to see you.
It feels like we haven't done this in a while.
Yes, you're right.
I miss you.
I miss you too.
So, Di, how are you?
I'm good, thanks. Thanks for having me.
Welcome, welcome. You know, the Counseling Center of Yorktown, how long has it been around?
Well, we have multiple facilities in New Jersey, in Georgia, and Florida. They've been around for about 13 years, since 2003.
And the one that you're at?
About 2 years.
Okay. And what brought you to the field?
I think in my senior year of high school, I had two very good friends before the opiate epidemic occurred that passed away from overdoses. And then I started to get more involved in working with adolescents in substance abuse. And then that progressed to working with people with substance abuse and co-occurring disorders with mental health issues.
And at the program at the Counseling Center, you deal with both co-occurring disorders and substance abuse issues.
Yes, I do.
And your clients come in?
Well, they're referred in different aspects. They can have legalities. They can walk to the clinic and decide to be a self-referral. They can be referred by family members, CPS. They can be referred by a multitude of different agencies and collaborations that we have.
Now, I've been at the facility, and it is really just really beautiful, a really beautiful facility you have there. So how many people can you service there?
We can service up to 100 clients, actually. It's a pretty big facility, has multiple rooms. We can have multiple groups at the same time. We do IOP and OP groups 5 days a week.
So what does that mean? What is
outpatient OP means outpatient. We have groups 1 and 2, so it's a group that is held for 2 hours. IOP is more intensive, so it's 3 hours, and that's 3 different groups. So that can be from relapse prevention to recovery education to addictive thinking. So each hour is a different component of treatment.
So then a person can come 5 days a week, like for an hour each day. Would that be IOP or?
They can come 5 days a week if deemed appropriately by the clinician who does the intake for 2 hours as OP. And if they need more, they would be IOP. That would be 3 hours, and that can be a day.
Up until what, about 9 hours for the week?
About 9 hours a week. Clients can come up to 3 to 5 days a week. The same thing with OP. If a client has difficulty maintaining abstinence, they can come. Treatment is increased because we work with the client to 5 days a week. We also have evening hours as well.
So now, what happens if a client comes in? Do you test them?
We do test them.
Okay, what's the tolerance level of the counseling center?
Well, the thing is that we really want to work where the client is at. You know, all the clients that come in are different. They're in different phases of treatment, and so it's really important to work what they're able to work with them at the ability they're able to be at. Some people come in where they're still actively using, but really want to put the work that it entails to try to titrate down. So we try to work with them in that level. And so if they have a toxicology that's taken, we can see eventually that they're not using as much. However, if clients have a really, really difficult time, then we refer them to one of our detoxes in New Jersey, to be detoxed or to inpatient treatment for assistance, and then they're referred back to us.
Okay, so your organization also is affiliated with inpatient.
Our organization is affiliated with, we have detoxes in Florida and in New Jersey. So we work in collaboration with them. We also work in collaboration with other facilities as well.
So if someone needed inpatient, you would send them to your program. And you have an inpatient program or no?
We do. We have a detox program.
Okay.
Yeah, we have a detox. We try to refer them to our detox, and then we refer them to another facility that can supply them with the services that they need, and then they're referred back to us for aftercare.
Okay, so would you say where you refer them to?
Actually, we refer, to all types of different facilities in this area, Arms Acres. We try to work in collaborations with all those facilities as well.
Okay. And Florida also, you mentioned.
And Florida as well.
Because a lot of people want to go to Florida now. Because it's winter here.
Right.
Yes, it's very nice. That's true.
But not actually, because the model in Florida is a lot different than the model here in New York.
Yes, it is.
With sober living components that help the person who's in recovery, early recovery, transition back into the community. So,
and I think our agency is currently in the process of also looking into sober living in this area as well. I think that's something that's open for discussion.
Oh, that's great.
In Westchester? I mean, in Yorktown, in this area, or Jersey?
In Jersey, I think predominantly Jersey, and then possibly, hopefully, if possible, in this area as well. Because we certainly need that here.
There was one here in Yorktown.
Oh, I'm not familiar.
Oh, yeah, Constellation.
That's right.
It was a sober
Recently
living,
closed.
and it recently closed.
Right.
It was a high end, pretty expensive, like $8,000 a month.
Right.
But it was gorgeous. I toured it. It was just, beautiful. And they had a lot of services there, but they couldn't make a go of it. It was, I think that not that many people could afford to spend that kind of money and stay there more than a month.
Right.
So it has to be affordable. So what do you see as a good point, in terms of being able to support people in early recovery that are not on Medicaid, and they have to pay privately for this sober living? What would you think is a good price point for that?
Well, I think what's really good about our agency, I mean, we do take private insurances, but I think when someone calls in and has some financial issues, we have a financial team that does discuss what is the person able to afford. They work in collaboration with that person.
So even for sober living, though? That's usually private pay.
I think that would be private pay. I'm not so familiar how they would go about that, but I think that if we really are, there's a need, I think the agency would gladly try to support the person to be able to attend.
Yeah.
That's good to know, really, because a lot of these places, people can't afford them. Medicaid, as we talked before, Medicare do not pay for sober living.
Right.
If you can find a place, it's not that many in Westchester County, but find a place that's privately owned, they're very expensive.
I just put a list on our website, by the way, of sober
Did
living.
you?
Yeah, we vetted some. We made calls. We vetted. We got contact numbers and names, and in the tri-state area. So we probably have about 12 on our website right now of sober living.
Definitely have to look at that.
Yeah,
up.
take a look at
Sure.
that.
In this area?
In the Connecticut and
Tri-state area.
the tri-state area.
Good,
Yeah.
because that's what people need.
Yeah, because that's what we feel that, and I'd like to get your opinion on it, that people are getting clean and then they're relapsing.
Well, particularly now, it's really difficult with the holidays for many people who are working on their recovery, family issues and a lot of depression, a lot of anxiety, the high expectations of what the holidays are, spending a lot of time alone, isolation. So it's really a difficult time for many of our clients now.
Yeah.
But also, I think because you go into treatment, you have 28 days, and you come out and you go to an outpatient, and how much has changed in the environment that you're returning to. In 28 days, if you're lucky to get 28 days, how much work is being done to heal the entire family, because it's a family disease. So the best thing is for people to go to halfway houses and stay under someone's care for 9 months to a year to get successful long-term treatment. What do you think?
I do agree. I mean, we have a family component to our program every Tuesday, and we also work with Susan. Susan does a meeting at our clinic, I think twice a month.
Twice a month.
Twice a month.
Right after your group.
Right after my group.
Meets.
So we do encourage families to get very much involved. My clinicians do family sessions with the family members on a regular basis if need be to educate many family members. Unfortunately, families are still in denial of this illness. This is a family illness, and it affects every aspect of the family. Many families have a difficulty accepting that their loved one is an addict, and it's not something personal, it's not a moral dilemma, it is an illness, and it needs to be addressed as such. It's a family illness.
And I think the Surgeon General, his report that came out that states that this is a brain disease, which last 10 years, we've been talking about in bits and pieces the last couple of years, really.
Yes.
But now it's out there on paper, black and white, for people to look at, take out the moral judgment, take out the blame, and look at this as a brain disease that changes how people's brain works and functions, and that's why they keep relapsing. And maybe that'll help take the stigma out, because that's the biggest thing you run across, is the stigma.
Right, that's what we're really trying to focus on this year, is the stigma, because, you know, the stigma associated with the disease really causes people to not get help.
That's right.
And only 10% of the people that need help are looking for help.
Right.
And that is just not enough, considering that we've had 3 deaths here in this area in the last couple of weeks. I mean, young kids. One was a girl and a boy, 30 years old, and all under 30. All right, so that's unacceptable, really. And you know,
why are more people angry?
Exactly.
Why
Why
are
are
more
more
people
people angry about it? It's like,
I think that people, they don't think it could happen to them. And I think, you know, this illness doesn't discriminate. It doesn't matter what social economic background you have, what the color of your skin is. It is an illness and needs to be addressed as such and not looked as a moral dilemma, like you stated earlier. I don't know why people are not angry. I know that we do what we can at the clinic, and our main priority is to provide quality care and to work where the client's at. And being involved with other agencies such as yours, Susan, and other outpatient facilities, and trying to work with the police department and the justice system to become more educated overall. So.
yeah, I think it's important to work on this as a community.
Right.
That's how we're going to. That's
Well,
how
it
it
is a
needs to be
community
attacked.
illness.
Yes. Exactly. Like if you talk, I can't tell you how many conversations I've had coming home from the airport. We're in a cab. The guy says to my husband, "You look very familiar." So Steve says, "Well, I was on a few commercials with Senator Murphy." He goes, "That's how I know you." He says, "I've had a problem. I'm in recovery."
Right.
Everybody we
That's right.
talk to
That's right.
either knows someone or is themselves, or
Right.
my uncle, or this one.
That's right.
And have you
Everyone.
had that experience? I mean, the minute you start talking about
Right.
it, someone.
I hear that a lot, actually. I've been stopped in the supermarket many times, or or putting some mail in the post office, or people say to me, "Oh, you look familiar. Are you from the counseling center?" I'm the clinical director there. "Oh, I have a friend that needs help, and do you have information?" Or "I have a friend's daughter or son." I hear that quite often. And then, what happens is they'll initially mention that, but then it doesn't follow through,
Right.
where the person who isn't really in need of the help is not getting what they need.
Right.
Right, it's just amazing. It really affects so many families, but still we're in denial.
That's
and
right.
still there's stigma associated. So can you tell how many counselors do you have on staff?
I currently have 3 counselors on staff, 2 females and 1 male. I have an art therapist. One of them is an art therapist. The other is a social worker, and the other one is an LMHC, a licensed mental health therapist.
Okay, and how about MAT? Are you medication-assisted treatment?
We're currently in the process of working through that. I'm a very big supporter. The clinic and the counseling center is a very, very big supporter of assisted treatment such as Suboxone and Vivitrol. Absolutely. We're currently in the process of working on that, having it at our clinic as well.
You know what, I just found out that Oasis wants to take methadone and change the model. No longer like it used to be, you'd go to the place, you'd get your orange drink, you drink it and leave. They want to make it as part of treatment, so that you'd go and you get your methadone, but then you would go to group.
I used to work in facilities that did do that type of model, where the person would go get their treatment and then attend their group therapies.
Okay.
Yeah, and I think that's what we would do once we get all the little quirks and things taken care of how to do that. Yeah.
So you're open how many days a week, from when to
We're
when?
open 5 days a week. Currently, from our groups start from 10 to 9.
Good.
Okay, we have the component for OP outpatient in the morning and IOP in the morning from 10 to 1 o'clock.
Okay.
And then the evening is from 6 to 9.
Okay.
Except Tuesdays, we have our family group at 6.
Okay. So you have a whole family group.
Yeah,
That's Susan.
Well,
group?
Susan does her group in our facility. We work in collaboration with her as well. We have a family group for our clients' family members.
And then they could stay for Susan's group
absolutely.
if they want.
We encourage that. We encourage that.
That's great.
To educate families about the disease concept of addiction, how to better set boundaries. Many of them struggle on how to handle the whole family addiction.
Right.
And so we encourage families to come to that.
And then you said something about...
Oh, I had mentioned earlier that we're considering opening up on Saturdays from 9 to 1 to do intakes and to do, a group.
That's great.
Because there's sometimes people are not able to make it during the weeks because of employment. So we're working on that option to have Saturdays open as well.
Do you have adolescent program?
We do see adolescents. I'm in the process of working on an adolescent track. We have like 7 or 8 adolescents, about 7 adolescents now. They come for individual sessions twice a week. And we have family sessions, of course, with the adolescents. And we are also in the process of working with schools in the area, student assistant programs as well, to offer our services.
In the school?
In the clinic.
In the clinic.
So they would come.
So they'll be able to refer for them to do group therapies as well with people their age.
Right.
So an adolescent program.
Right.
So you're working on that now?
Yep.
Yeah. Okay.
Yep.
So that's what's needed, more adolescent programs.
Well, that's true. That is definitely what's needed. But really, I think that we need to get these kids when they in the very early stages of use.
The intervention.
So when they're first experimenting, and no one knows when they're first experimenting if they're going to be addicted, if they're going to wind up being an addict. You just don't know it, and the parents don't know it either. So this is my opinion that it's a gap that needs to be filled so that before they're addicted or before they're arrested or before they really get in trouble, but the parent finds out that they are using, I found pot in my son's pants. That's how I knew he was using. At that point,
you need to
begin to do an intervention so that now the parents get the education, the kid gets the education, and follow-up is made to the parents so that you see if the kid used again, got in trouble again, and then in that case, if they do continue to make the wrong decisions, to be referred for an assessment.
Well, I'm a very big supporter of preventative services in school. I think what's really important too is that parents really have a hard time accepting whether their children are using. They kind of minimize cannabis abuse and drinking on occasion as a rite of passage.
Yeah.
And unfortunately, it is not. Not every adolescent goes through that. And so sometimes when that does occur, people don't address the issue. They kind of put it under the rug like it's not that important. And then what happens is the progression of the illness. The person may be using something else eventually. That's what happens.
Or just using that if it's alcohol. Alcohol addiction is very serious.
Yes, it is.
Very difficult to overcome. So what I say to parents is, drinking is illegal until they're 21 years old. That is all you have to say. This is illegal. There's the line in the sand. You cannot drink because it's illegal. I don't care if your friends are doing it. I don't care if you're at a party where they are. Our tolerance level is zero tolerance because it is illegal.
But a lot of parents do not believe that. They let them drink at home. They rather them drink in the house. They'll be safe. I mean, the parents come up with all these excuses why it's okay for kids to drink in the house and then have their friends come over and drink. So maybe they're not providing the alcohol, but they know what's going on. And then I don't get it sometimes, social hosting. I mean, don't they know they can get in trouble, they get arrested? I mean, what's...
I think people have a hard time kind of deciding whether to be a parent or a friend. I think that when you have children, the responsibility is you're a parent, you're not their friends, you're not meant to be their friends. And so that can be difficult sometimes for many, many people. Social gatherings of that nature are definitely very, very serious and illegal, and can be very costly legally if you're caught doing something like that. And also sends the wrong message overall
That's right.
to not only your own children, but to the children of the community, that this is okay, that this is occurring. And yeah, it's not acceptable behavior at all.
And I don't know how we break that, because, I go around to different communities and I hear the same thing. I don't care what community. There are parents who let kids drink in their home, and other parents are afraid to say something because they don't want to be ostracized from the group or the community, and they don't want their kids not to be invited to these parties and these social gatherings. I tell these parents, it's illegal. Don't send your kids, or call the parent and say, look, you're having alcohol in your house. No one wants to cross that line. And it's sad, because you're right, it does send a bad message.
Well, I think popularity is overrated.
Right.
And I think what's really important is that, how would they feel if their child got in a car and got into an accident and died or killed someone else? Does it have to go to those extremes for people to make change?
I think it goes back to what you said. People don't think it could happen to them.
Absolutely.
That's why you have 3 people that just died, and my heart breaks for their families, and no one is angry. You just don't hear about it. I found out about drug crisis in our backyard because you wrote that letter to the newspaper Mayapack, and you were angry.
I was angry.
You were angry,
and I wrote an article for the newsletter, and I'm angry.
And I'm angry, right?
I'm a very angry person,
and you're allowed to.
Let's face it.
Let's face it. Yeah.
I might have a smile on my face, but I am angry.
Right.
Okay?
Yes.
I am angry that this happened to my family. I'm angry that it's happened to my son. He's 20, he was 29 years old. And that's what keeps me going, is my anger. Once I lose the anger, then
we're not going to let you
I have to
use
get another job.
Nope. We'd be lost without you, because that anger, it has polarized a community, but not enough, because not enough people feel that outrage. And I don't know what it's going to take. I don't know. 5 minutes. I don't know what it's going to take.
I don't know.
Do you hear that? Do you hear that from parents in your...
I do hear that from parents. I got a call this morning from a lady who said, my son graduated college and he's drinking, he's been doing cannabis for a long time, and I just don't know what to do. People feel paralyzed. They don't know what to do.
So what do you tell them?
I tell them to come visit my clinic or call a health care professional, treatment facility, speak to a clinician, to someone. I took the time to speak to the lady. I encourage her to come to the clinic. I encourage her to call me again. I encourage her to speak to her son. We definitely put out as much information as we can to support the person going through their crisis to come in through the door and see what we can do for them, or refer them to another agency that can assist them with what they're going through.
Or the support group.
Right.
I've got a lot of calls, I'll tell you. Since Thanksgiving, it's been on fire. And yesterday I spoke to someone, and I gave them the whole rundown on MAT, because she told me her relative had been using for 13 years.
Wow.
That's a long time.
And
she started very young, heroin. And, she probably needs to be on some kind of medication-assisted treatment to stop. After 13 years, it's pretty hard to get off.
Oh, absolutely.
With heroin. I also refer people to your clinic, because I think it's very well done and it's beautiful. And think that I know your counselors are excellent. And so I think they're going to get a great experience there when they go in. They're going to see that they can relate to it.
I think it's important that the clients feel comfortable, that they feel safe, that they're respected, and that's what we offer there. And it's very individualized therapy.
Right.
So that's really important.
So let me ask you, how do you feel about harm reduction?
How do I feel about harm reduction? In reference to someone,
they're not using heroin, but they're smoking pot. They stopped using heroin, but they're smoking pot.
They're still using.
Yeah, heroin.
Yeah,
so is that your opinion? They're still using.
Okay. They're still. I mean, as I know now, New York State doesn't have a legalization of cannabis, so it's not legal.
Right.
And so if you're smoking weed, you're still using.
Okay. So your stance on it is abstinence. That's the goal, total abstinence.
Yeah, the goal is overall abstinence. Yes.
Okay.
But my question is, and how much, we're almost out of time. It sounded like when you first started talking, and help me if I misunderstood, that you'd work with the client. So if they stop shooting dope, heroin, and now they're smoking pot,
we would like them to eventually titrate down to
so
cut
you believe
down.
in the harm reduction model?
Yeah, I do believe in the harm
that's
reduction.
That's what I thought.
Yeah,
Okay.
yeah.
A lot of places don't. It's abstinence or
Or they
nothing,
get kicked
or
out.
out.
No, we really work with the clients. We've
what I
had many
thought.
clients that come in with multiple substance use of different substances. So they may worked on stopping on one particular substance, so we'll work on the next one.
Right.
That includes cigarette smoking as well.
That's harm reduction.
Yes.
Good. Good. Because I really think that's the way to go. I can't. I don't like when you come in because, and total abstinence, you have to work towards it.
Oh,
you
absolutely.
cannot say you've got, like, by the end of the week, you better be clean and your urines in 2 weeks have to
Unless
be
you get
clean.
kicked out.
Unless you get kicked out.
No, we
and
don't
it's
do that.
punitive.
No, we
Yeah,
don't
it's
do that.
Freaking punitive.
We
And
don't
then-
do that.
Then you go through this cycle and you wonder why someone has 90 treatments.
Right, exactly right. That's why they put a lot of money. They're putting a lot of
Right.
money in. The insurance companies have a right to be angry.
That's right.
because
angry.
because it's a revolving door.
That's right.
And something has to
And
change.
Medicaid.
The model has to change.
That's right. The model absolutely has to change. And we were talking before about Medicaid. You don't take Medicaid or Medicare. You're straight private pay
Or
or
self-pay.
insurance,
Yeah.
self-pay or insurance.
Yes.
But people have used the Medicaid as the gold card. I remember having a client, St. Vincent's, one day, the inpatient, 90 treatments. 90 treatments. He started using at 5. I got him at 48. Used all that time.
Wow.
It's a lot.
It's a lot of treatment. We have to change the model. We really do have to
Yeah, I
change
think
the
it's
model.
important to change the model.
Because it's not working. And I don't think 85% recidivism rate is something to be proud of.
No, it's not.
So, we're running.
Anyway, it was wonderful having
Did you
you
believe
on.
at the time?
Yeah, thank
Yeah, so-
you.
You were worried. You didn't think it. It's easy. Thank
great.
you.
Thank you.
We're happy to have
Thank
you
you for
on,
being
and
here.
you have a great facility. And I recommend anyone that needs treatment for alcoholism or substance abuse to call Melendez, Drier. At
What's
wanna
your
give
number?
you a
Shoot, talk to the camera. Give him your number.
914-591-5101.
And your information is on as we roll.
Okay,
the
great.
credits, all your information is
Great.
there. There you go for the counseling center.
Great.
Thank you for
Thank
being
you.
here. You're great.
Thanks.
Thanks
Keep
for coming
talking.
on.